As you can see, uh, this is the Forrest classification of peptic ulcer bleeding based on endoscopic appearance. It's used to stratify bleeding risk, guide treatment, predict re-bleeding and mortality. Now, uh, as per this classification, you can see this Forrest classification 1A, 1B, 2A, 2B, 2C and 3. In 1A there is active spurting, and in 1B there is oozing, and in 2A there is visible vessel but it's not bleeding, whereas in this case 2B there is adherent clot, and 2C there is flat pigmented base, 3 is clean ulcer base. Note that risk of bleeding is very low in this case, type 2, and there is no treatment required in 3 and as well as in 2C. So no treatment is required in case of class 2, class 2C and class 3. This is class 3. Whereas in this class 2B, where there is adherent clot, so the risk of rebleed is intermediate, and treatment decision is you have to treat if clot is removed and vessel is seen. So treat if clot removed and vessel seen. So if patient has active bleed and patient is unstable, so think of a hypotensive, pale, sweaty patient vomiting blood. You are in the ward and you see this active bleed plus hemodynamically unstable patient. Likely patient is in 1A, that is there is spurting, or if patient presents with hematemesis with tachycardia, always suspect class 1 bleed until proven otherwise. And also take history of NSAID intake, alcohol, steroids. These are clues for this underlying peptic ulcer disease. And any patient with dyspepsia plus recent melena, refer for urgent endoscopy, because delayed referral can cost lives if it is 2A or 2 or 1B. So in 1B there is oozing blood, and in 2A there is non-bleeding visible vessel, but they will be having dyspepsia, although they will not be presenting with melena or hematemesis. But you should, whenever you encounter any patient with dyspepsia plus recent melena, so recent melena means patient was recently in 1A stage, now there is still dyspepsia plus recent melena, so patient can be in 1B or 2A stage, so urgently refer for this urgent endoscopy. So as per Harrison, this Forrest 1 and 2A, so Forrest 1 and 2A lesions are high risk and benefit from dual therapy. So what is this dual therapy? One is epinephrine 1:10,000 plus hemoclip or thermal coagulation. So this is this dual therapy. So patients with Forrest class 1 and 2A lesions are high risk and definitely benefit from dual therapy, that is epinephrine injection 1:10,000 plus either hemoclip or thermal coagulation. And how much volume do we inject? We inject a volume of 13 to 20 ml epinephrine, that's mandatory. And epinephrine alone reduces active bleed but does not prevent re-bleed, hence always combine. So epinephrine will reduce this active bleeding, but it will not prevent re-bleeding episodes. So you have to combine it with thermocoagulation and hemoclips. Now for example, if a patient has an ulcer with a visible non-bleeding vessel, how do you manage? So this is class 2A, so you have to treat with dual therapy, that is injection plus hemoclip. Now if a patient has an ulcer that has a clean base, so this is class 3, no endoscopic treatment is required, and you can continue IV PPI for 72 hours to reduce acid and stabilize clot. So endoscopic management is not required in class 3. You do not do epinephrine injection or this thermocoagulation and hemoclips. You do not use these in class 3 lesions. And as per NEJM 2021, there is this combined therapy reduces rebleeding rates by 30 to 50% as per NEJM 2021. And recommend avoiding epinephrine monotherapy due to high rebleed rates as per ESGE 2021 guidelines. So don't use epinephrine injection alone because it will cause higher rebleeding rates. So spurting is 1A, oozing is 1B, visible vessel is 2A, adherent clot is 2B, flat base is 2C, clean base is 3. So any hematemesis is potentially Forrest 1A until scoped. No clean base, no comfort, treat or risk of death. And never trust an adherent clot, so you have to probe it. Epinephrine alone is incomplete, so you have to combine or you will later on regret. So for example, a patient 50-year female comes with melena plus tachycardia, endoscopy reveals visible vessel, that is 2A. You will inject straight away 13 to 20 ml of adrenaline, 1:10,000, plus you will give hemoclips and you will give IV PPI for 72 hours to prevent rebleed. So final clinical hacks. Suspect PUD bleed in elderly on NSAID or aspirin. Always combine endoscopic therapy when possible. Don't rush to label a flat pigmented spot as safe in high risk patients. Always do PPI post endoscopy even if no active bleed is seen. Stabilizes clots, that is the standard of care. Now question is, what about this Forrest class 2B, that is this adherent clot? This is a bit tricky. An ulcer with a firmly adherent clot over the base, you cannot see if there is an underlying non-bleeding visible vessel, that is 2A, or there is this oozing vessel, that is 1B. So this becomes a tricky. Why is it tricky? Because patient, it looks stable but may be hiding a high risk lesion underneath. Because we know if a patient has this non-bleeding visible vessel, then patient could be this 2A, but if there is this oozing blood vessel, when you remove this clot, he could land up in 1B picture. That's why the clot may be covering a ticking time bomb. So you have to understand this thing. So management strategy, what do you do? One thing is guideline based answer. As per Harrison 22nd edition ESG or ACG, you will do what thing? You will attempt to dislodge the clot gently during endoscopy by using water irrigation, that is jet, by doing suction or cold snare or gentle probing. Then if this visible vessel, that is 2A, if there is visible vessel, that is 2A, or active bleeding, that is 1A or 1B is seen underneath, you will treat aggressively with epinephrine injection 13 to 20 ml of 1:10,000 plus thermal coagulation or hemoclip, that is this dual therapy. But if nothing is seen underneath, that is there is just a clean ulcer base, so stop there. No further endoscopic therapy is needed. So but if clot cannot be removed, it is too adherent, unsafe, then you will still treat it as high risk and give IV PPI for 72 hours. But some guidelines suggest considering empirical endoscopic therapy, that is clip or thermal, at base of clot, but this is debated. And why this matters? Why not to leave the clot alone? Because 22 to 33% of 2B lesions, that is this adherent clot lesions, hide a visible vessel underneath. If you miss it, there is high risk of rebleed. Patient can land up later on in shock and patient can die. So this Y probe instant why you should do this probing instead of clipping right away, because if you will do clipping of this clot without seeing the base, it's like locking a door without checking who's inside. So for ulcers with an adherent clot, the clot should be gently dislodged to assess for an underlying high risk lesion. If visible vessel, that is 2A, or active bleeding is uncovered, that is either 1B or 1A, endoscopic hemostasis, that is dual therapy, should be given. Now a question: a 60-year-old patient undergoes endoscopy of melena, adherent clot is seen over a duodenal ulcer. Forrest 2B, what is the next step? So you remove clot to visualize base, then treat based on findings. Adherent clot should be removed when possible. Endoscopic treatment should be applied if high risk stigmata, for example visible vessel or visual and this active oozing, if they are visualized beneath.